Thanks very much, Grant. It's great to be here, and we're going to make this sort of informal. We invite your participation. We're going to be talking about a topic that I guess is a bit sensitive. We're going to sort of expose perhaps a little bit of dirty laundry within closed quarters and talk about, where errors can be made. And I think we have to understand that errors do occur in decision making at all levels. For the cases, we will be using the app for you to vote, so you do need to download the app onto your smartphone if you're going to participate in the voting, the anonymised voting. Is it turned on?
Yes. Yeah, it's working.
Okay, all right. Can you hear me now? Okay, perhaps come a little closer. Thank you. All right, so just to give you, I guess to start with, a little bit of an overview of what we're going to be doing. So we're going to talk a bit about the epidemiology of diagnostic error, then talk about some of the cognitive biases that cognitive psychologists and sociologists and others now have identified, particularly in the medical sphere. Talk a bit about de-biasing strategies, what we can do to counter some of these biases, knowing that perhaps the research in this field is still developing. And then we're going to move on to the case studies. And we have 4 case studies. And we're going to get you to vote in terms of what you think are some of the errors that people have made in some of these cases, and also what some of the cognitive biases are that perhaps underpin those errors. And then David's going to have some closing comments in relation to safety and systems more generally. So let's talk a bit about diagnostic error. There is a taxonomy of diagnostic error. There's the delayed diagnosis, but in the end it's correct. There's a wrong diagnosis, which clearly is something we want to avoid, or there's a missed diagnosis. In other words, the diagnosis that's there has never been actually uncovered as such. I think the prevalence of diagnostic error, that particularly in the US, that people have identified, is certainly not that uncommon. It's about 10 to 15% overall diagnostic error rate in hospital medical wards. So about 1 in 10 to 1 in 8 of our cases, there'll be some diagnostic error. Clearly not all of those are going to result in serious harm, and in many cases it's really a situation of a delayed diagnosis rather than perhaps a wrong or missed diagnosis. But nevertheless, about 1 in every 100 of those errors can result in significant or serious patient harm. In the US, they've estimated that it's about 40 to 80,000 deaths per annum across hospitals as a result of diagnostic error. So when you put it in those terms, perhaps at an individual hospital level, it may not be many, but across a country, it's significant. Brennan et al. Found that 17% of adverse events in hospitalised patients were related to diagnostic error. Post-mortem studies, which, in a way is the final arbiter of a correct diagnosis, reveals that 5 to 20% of those post-mortems disclose potentially treatable lethal diagnoses that may not have been either recognised or were under-recognised during the patient's illness. 10 and more, if we come more recent, more close to home in New South Wales, using the New South Wales Health IM system, 10% of SAC1 incidents, these are serious incidents, and 20% of SAC2 are related to diagnostic error. So I think that puts it in perspective as well. And amongst the surgeons, to include our surgical colleagues who perhaps are even more aware or more attuned to the effects of error, 13% of audited surgical mortality cases also identify a diagnostic error or delay. There are other consequences also. Not, as I said, all patients come to serious harm, but certainly a wrong diagnosis or delayed diagnosis can engender patient dissatisfaction and distrust. Malpractice claims are certainly a concern, certainly from a hospital risk management point of view. Clearly we have increased healthcare costs because if we make a wrong diagnosis or delay a diagnosis, that incurs usage of tests and treatments which may not be appropriate, and that's a form of waste. And also, finally, I think for us as clinicians, professionals, we're harmed psychologically if we've made a serious misdiagnosis or incorrect diagnosis. I think it's important to say that all physicians are subject to this faulty reasoning from time to time, despite your talent, dedication and compassion. We're all vulnerable to diagnostic error. So I think that's the first thing we need to accept, that if we're going to expose, interrogate and try to remediate diagnostic error, we have to recognise ourselves that we're all subject to this. Before I move on, can I just have a show of hands, basic trainees here in the audience? Okay, hands up, good. Okay, advanced trainees? Good. Fellows of less than 5 years? Okay, fellows of 5 to 10 years. Fellows of more than that. Okay. All right. That's interesting. Now that is interesting. I would have thought trainees perhaps would have been flogging to this session, but we seem to have a lot of experienced clinicians here as well. So perhaps that may be that with wisdom and experience, we've all experienced diagnostic error. Okay, so, I mean, people talk about the system and the cognitive components of diagnostic error, and there's no doubt that systems sometimes can make us more vulnerable to an error. And people have tried to break it down in terms of, well, what percentage of diagnostic errors are due to system error only? So, for example, failure to report a diagnostic test, the records go missing, there's some other system glitch, poor communication between one practitioner and another. Okay, well, about 1 in 20 of errors may be purely system, but the remainder, the other 80%, do involve some degree of cognitive error. Okay, and in some cases, about at least a quarter, it's more or less pure cognitive error alone. So there is an interdependence between system and human, but nevertheless there is a strong predominance of a cognitive component. I think that this is a very useful book if you ever happen to pick it up and read it, Thinking Fast and Slow by Daniel Kahneman, who's a psychologist but also has done a lot in health and done a lot in economics. And he basically decided there's two systems of thinking: intuitive, which is fast and easy, based on personal mind lines, that's our tacit knowledge of how we approach clinical problems; heuristics, which are mental rules of thumb, shortcuts, and beliefs, judgments, and preferences. And it's accurate for most of the decisions we make, but it is vulnerable to bias. Most of us, though, certainly experienced clinicians, about 95% of the time, we use System 1 intuitive thinking. But that's the form of thinking that's most vulnerable to bias. System 2 is more analytic, it's slow, it takes effort, it's based on science, it's more rational, okay? But nevertheless, our preference is System 1 thinking, simply because it's fast, efficient, and in most cases, it gives us the right answer. But what we need to understand in looking at debiasing in relation to cognitive error is to realise when do we need to shift from System 1 to System 2. Here are some of the more common biases that we're going to be encountering in the cases. Now, psychologists have identified now more than 40 to 50 different forms of cognitive bias. So this is a growing field. Having said that, a lot of the literature seems to be a little bit overlapping. People kind of rename one bias a little differently. But to me, these are the ones that are most important. Anchoring in premature closure, where we focus narrowly on a single feature in the presentation to support an hypothesis, but don't look at other features, other clinical symptoms and signs that would refute that diagnosis. Availability bias, tendency to think diagnoses that come immediately to mind are more likely or more common. And this is what I call the grand rounds effect, where people see esoteric cases at grand rounds and then think if a patient comes along and has somewhat a similar presentation, this comes immediately to mind and they start thinking, could this be another pheo, right, or adrenal corticocarcinoma, for example. Framing effects, disproportionately influenced by how a problem is described, by whom, the setting, what has previously been accepted as a diagnosis, the diagnostic momentum. So people may be primed to think in a certain way simply by virtue of what the ED physician has told you, what is written in the chart as to relation to past diagnoses which may not have been verified, etc. So we're framed to think in a certain way just by the way the problem is presented to us. Base rate neglect or representativeness bias. Here's a tendency to significantly overestimate the likelihood of a diagnosis because the problem has some features representative of that diagnosis. So we kind of forget what the pre-test probability of this condition is, even though it has some features which suggest that is the diagnosis. And then there's affective bias, the effect of emotional influences on thinking, including feelings towards their patients, both positive and negative. And we have to understand that we are humans and some patients do upset us. Right? And that's where we have to really sort of try to think in a System 2 fashion. And then there's overconfidence and blind obedience, where essentially we accept what perhaps other people suggest is the diagnosis, tend to think that we know more than we actually do, okay, and place too much faith in the opinions of others. So what are the situations where these cognitive biases are more likely to occur and increase the risk of error? Handovers from one shift to the next or from one unit to the next. Time pressures, clearly, high patient volumes, a distracting or interruption type schedule. Individual physician factors, clearly if we're fatigued or deprived, sleep deprived, personal stresses, we're cognitively overloaded, our training and experience may not be sufficient. Patient factors, again, the uncooperative or difficult patient, the patient has a bad reputation, the heart sink patient, the patient who seems to be presenting with a difficult somatoform disorder, etc. And then finally, the environmental factors that we've mentioned already. These are the situations that sort of predispose to error. And some of those are environmental, but the others pertain to our individuality. So what are the cognitive debiasing strategies that we can use? Well, essentially, I think these are the questions we should ask if we're in any way disturbed or concerned. What else could this be? So think more broadly, think about the differential. Is there anything that does not fit? I'm proposing a diagnosis. Does it really explain all the key features? What can't I explain? Is this an atypical presentation of what is perhaps a common presentation? What should I be most worried about and why? So yes, we have to look at what are the serious red flag, bad case scenarios that we need to exclude in a patient, but without over-investigation, however. How does this patient make me feel? So if I'm already feeling a little bit tense and anxious or perhaps put off by this person, okay, need to just be aware of that. Is it possible the patient has more than one problem? And that certainly is an issue when you come to older patients in particular who have multimorbidity. Is there any other reason I need to slow down? So it may be just time pressures, I'm feeling a bit off colour today, I'm feeling a bit harassed. And do I need more expertise to assist me in making a diagnosis? So should I seek a second opinion? Should I get a colleague to come in and perhaps also review the case and just act as a sounding board for me? There are some useful resources which I'll just quickly put up, but this presentation will be available on the website. The websites in particular I think I would make note of: the Society to Improve Diagnosis in Medicine, the Diagnostic Excellence site, which I think is a very good one, and of course our own RACP Diagnostic Error Q stream. Can I just have a show of hands who's done the Diagnostic Error Q stream? Okay, all right, so there's some. But you might like to look at that. I think it's a very useful resource. Okay, so let's move on to some of the cases now with that introduction. So again, it's the App Store search, RACP Congress. Okay, log in with your registration email and the password is 2017. So perhaps you might like to do that now if you haven't already done so. We'd like as much participation as we can. Hopefully you're all tech savvy.
Can I just observe that it's probably more stable if you log in to their Wi-Fi first up rather than trying to run it on 4G. It seems that the 4G is not very good inside this building. The Wi-Fi access, the username is RACP Congress, the password is RACP 2017.
I think it's just 2017, I suppose. 2017 is for the app.
For the app. So Wi-Fi, it's RACP 2017 for the app. As Ian said, it's your email address with which you registered, and 2017 is the password.
There should be a test question.
It's frozen today a lot of the time.
Okay. We can fix some things, but we can't fix everything. Charlotte, have you got any thoughts?
Once you're in the app, if you go to the voting page, all of the questions will be on there, and the test question is the first question for the day. It's like hang. They just hang and they don't actually send to
Okay. So, if you do get into the app, you need to go to today's session, which is Shared One Medical Breakthroughs in Future Practice. What were you thinking? And down the bottom of the page, once you open that, you should see a tag called Voting. Yeah.
Before we want to make a test question, just to make sure this works for you all, does anyone need a hand?
A tech-savvy audience. Fantastic.
All right, so can I perhaps have a show of hands who's actually on site? So the question
Dr.
again
Brown,
was,
are you in?
hands up those who are now logged in, who are ready to go. Because you may have to just keep moving, guys, otherwise
Yep,
we're going to run out of
we
time. Okay, hands up those who've got the test question in front of them. Right, okay. Would you now please answer that test question? Vote on it. Okay, so you have...
That's correct. Yep. That's right.
Okay.
Okay.
All right, so we'll just refresh this just to make sure we got the most recent number. Okay, so we have 90 votes and we have a predominance of males. We have a certain percentage that don't prefer to answer. Okay, so you're obviously transgender or bisexual, and unfortunately we can't actually counter that. All right, good. Okay, all right, so we'll move on then to the first case. The case one, and I'll just read it out, but you can read it yourselves, but I'll quickly just read it through. So we have an 87-year-old man admitted with a diagnosis of ACS, treated with antithrombotic treatment comprising clopidogrel, aspirin, warfarin. He's got a history of COPD, chronic kidney disease, hypertension, AF, for which he was already warfarinized prior to admission. Just prior to presentation, he developed a cough productive of brown phlegm, mild fever. On day 2, his INR was found to be subtherapeutic and enoxaparin was added until warfarin was therapeutic. On day 4, he's wandering the ward confused and disorientated. The junior house officer assessed him and found him to be clammy, diaphoretic, but did not review the medical records as she was familiar with the patient. She was the team member. Vital signs showed he was hypotensive and mildly tachycardic. The junior house officer then called the on-call med-reg, who was busy seeing patients in ED, but had seen the patient earlier in the day, thought the patient was likely experiencing an acute delirium secondary to sepsis from a lower respiratory tract infection in view of the productive cough. Sepsis management was initiated and the case was handed over to the night resident then for follow-up. During the night, the patient, however, deteriorated, becoming more hypotensive and tachycardic, and was found then on urgent CT imaging of the abdomen to have a large retroperitoneal bleed. Emergency resus and blood transfusion and cessation of the antithrombotic treatment was initiated. However, he subsequently died from multi-organ failure a few days later. So the question we're asking you is, okay, what are the factors relating to the diagnostic process involving this patient that led to the delayed recognition of a complication of anticoagulation? And here are the options. So, A, poor communication between the JMO reviewing the patient and the medical registrar on call regarding the patient's current clinical status. The junior officer failed to perform a thorough physical assessment of the patient. The patient was difficult to assess because of his disorientation and confusion and was unable to provide a clear history. Or inadequate assessment and consideration of a differential diagnosis by the medical registrar, or all of the above. So all these factors may have a role to play. We're really asking you what you think is the most important predisposing factor here. So would you like to now vote, please? A, B, C, D, or E? If our technician is here, can we just dim the lights a little, please? Good. Have you all voted in? We did find that the server, unfortunately, again, is slow in relation to the polling, but we will get there in the end. I should also add that there isn't necessarily that you may not agree with our so-called correct answer, and that's fine. But anyway, let's have a little look. Okay, so the majority felt that really all these factors were relevant. 64. We have inadequate assessment and consideration of differential diagnosis by the med-reg as number 2, and then a small smattering of the others. Okay. All right. Well, we agreed with number 2. We felt that the most the important issue here was that there was inadequate assessment and consideration of the differential diagnosis by the medical registrar. Okay, so the next question that I want to ask you is that in this diagnostic error, what do you think was the main cognitive bias? Okay, so just put that slide up again from what I showed you before. Was it anchoring or premature closure, availability, framing, base rate neglect, affective bias, overconfidence, blind obedience? So would you like to again now to vote A, B, C, D, E, F or G? Knowing again that perhaps there may be more than one bias that influenced this case, but what do you think was the predominant one? Okay, good. For those who ask the lights to be dimmed, unfortunately the technology is not working up here.
We're trying.
We're trying. All right, all locked in? Okay, so we've got a bit of a spread here. So we have 64%, about 2/3 went for anchoring and premature closure. The next one is 16% is framing effect. The next is, looks like it is availability bias, and 5% thought overconfidence. Okay, all right, well, we agreed with the majority. We felt that anchoring and premature closure was the problem here. And I guess that the provisional diagnosis of sepsis secondary to LTI was really, I think, accepted too readily. And it brought that, then the whole thinking process was brought to a premature closure. Before, really, the registrar should have thought, well, what other possibilities could it be, and what are the things that don't fit? And clearly, while sepsis, oh, that's good, thank you. While sepsis needed to be considered based on the fever, the cough, the history of COPD, etc., the sudden onset of confusion and hemodynamic instability in an elderly patient receiving that sort of aggressive antithrombotic treatment you have to think about, okay, is this an acute bleed into a silent area where the patient may not necessarily complain of pain? And we know that retroperitoneal bleed sometimes can be associated with very little by way of pain. It can be associated with back pain, sometimes abdo pain, but at times it can be quite silent. Okay, so that's good. Are there any questions people want to ask before we move to the second case? Yes. Please, we'll just get a microphone.
Charlotte, microphones? We do have a couple of roving microphones, so please
I just
pop
wait
your hand
until
up
we
so
get
that
the
we can see you
microphone.
clearly,
All right, otherwise we may not hear you.
particularly now that it's dark. No, we're not putting the lights up.
Can you just put your hand up again?
Charlotte down the front. Thank you.
I guess this case shows, Karen Dunn from Melbourne, what many situations are that you've got junior doctors looking after complex patients late in the evening, and we're judging the decision-making of the registrar based on the ability of an expert. So we're going, well, the consultant would have picked this, but where was the consultant? Mm-hmm. They're not there.
Mm-hmm. Absolutely, and I agree with you. And I think that, as we mentioned, one of the things that certainly junior staff should think about, okay, what's the worst case this could be, and do I need to seek expertise in helping me make or confirm this diagnosis? But I think what we're trying to do in this workshop is enable that registrar also now to become aware of where they may have gone wrong in their own decision making. I mean, obviously we're trying to train folk to move to their own autonomy, and that they can make these decisions themselves. Yes, consultants should be there. I worry a little bit about that sometimes we're a bit too consultant-led and consultant-driven, and perhaps then these skills aren't really developed as well as they should in our trainees. But I understand we don't want to put patients at risk either by not having that supervision. So to me, it's a bit of a continuum. Okay, the object here, I think, is to share these cases with trainees, right, of which there's perhaps not quite as many here as we would like, okay, to actually think this through. Certainly if we can protect them and make them less vulnerable to an error, that must be, I think, a good thing that we should strive for. All right, if there's no further questions, we'll move on to the... Yes, no, and there's another question.
Please just introduce yourself and tell us where you're from.
I'm Kim Jess, I'm a geriatrician in Melbourne. At our hospital, that would have been a MET call, which would have naturally brought in a system approach, which might reduce error, because the other person standing around that patient might well say, hey, couldn't they have bled?
Correct. Agree. And this is certainly not a case for doing away with MET calls or rapid response teams. Okay, so, there may have been other pressures, time fatigue, that may have caused MedVeg to rely too heavily on information relayed by the JMO and her previous familiarity with this patient. Okay, case 2. Flynn is a 17-month-old boy with a 2-day history of malaise, loss of appetite, runny nose. After developing a temperature and a sore throat, he's seen by the GP, who diagnosed a viral illness with possible tonsillitis, but there was no signs of pus requiring antibiotics. Over the next 2 days, he develops vomiting and erythematous rash spreading from his groin, under his arms and behind his knees. He's taken back to the GP. Seen by a different GP on this occasion, who fitted him into his busy clinic, who noted worsening tonsillitis and commenced antibiotics. Later that evening, Flynn, though, became irritable, more unwell, his rash had spread, and his parents took him to the local ED. At the ED, the previous 24 hours, there had been several presentations of young kids with viral illness over the last few days. There was a bit of an epidemic. The ED doctor reviewed Flynn, noted that his symptoms were very similar to those of a number of other patients on that shift, determined that the rash was probably either a viral exanthem or possibly a reaction to the antibiotics that had been given by the GP. He was prescribed antihistamines, was sent home, but his parents were a bit concerned about this. He remained unwell, lethargic and flat, was taken back to the GP the following day, and at this time he was seen by the first GP who had seen him, who identified a significant deterioration and immediately sent Flynn to the tertiary referral paediatric facility. Following admission, Flynn was diagnosed with streptococcal bacteremia, which was promptly treated, and he recovered well with no long-term sequelae. So which of the following factors here do we think potentially contributed to the delay in Flynn's diagnosis? So was it the second GP missed the significance of new symptoms of vomiting and rash and did not take the opportunity to re-evaluate Flynn's problem? Was it because the differential diagnosis of post-viral rash or antibiotic reaction was based on the most prevalent conditions at the time and was insufficiently comprehensive? The ED doctor interpreted Flynn's symptoms as being concordant with his impression of viral illness. The seriousness of Flynn's condition during his first presentation to ED was not recognised, which, if it had, may have justified monitoring his condition, at least for a period of time. E, all of the above, or none of the above. The course of action was reasonable based on the difficulty, in many cases, in separating bacterial from viral illness in young children. All right, so would you like to vote on A to F on that question? Okay, you're all in. Time's just about run out. Good. Okay, so we have a bit of a mix again. Though the majority felt that all these factors were irrelevant. 16 folk felt that I think that's right. Let me just push this down a bit. Okay, so 44 thought all above were of significance. 16 felt the differential diagnosis of post-viral rash or antibiotic reaction based on the prevalent condition at the time was insufficiently comprehensive. Okay, 18 thought that the ED doctor interpreted Flynn's symptoms as being concordant with his impression of viral illness. Okay, I think on this question we did feel, well, there probably would be a number of different answers, and we don't necessarily think that we have necessarily the right answer, but we felt that all these things were relevant in this particular case. And it was hard to sort of isolate one factor in particular. So I think this is a situation where clearly there are both system issues, there's discontinuity between different doctors, so that the patient wasn't being seen by the one person who perhaps could have noted there was a deterioration. But if we could get you to vote, though, nevertheless, on what you think was the main cognitive bias in relation to the management of this case. So again, A to G, anchoring, availability, framing effects, base rate neglect, affective bias, overconfidence, or blind obedience. So again, would you care to vote now on that?
Just while people are thinking, there is one spare seat down the front. I think. Is that right?
Yes, there is. There's also 2 spare seats up here in the lectern if you want to be up here.
The expert.
Okay, so what do we see here? We've got about a third for framing effect, about another third had availability bias, 14% thought it was probably affective bias, a base rate neglect, right, and another 11% thought it was anchoring. Right, so, it's a spread. And you're right, there could be a number of different cognitive biases operating in this patient. Our decision was that we felt that probably the availability heuristic was the one that perhaps was most likely to have caused some misthinking around this case. In other words, the clinicians, their recent experience with viremia, that's common, right? That's what's going on. This patient seems to have a lot of features consistent with that. But the thing is that the red flags weren't thought about. That is, the child's deterioration despite the antibiotics, if they thought it was a bacterial tonsillitis, the onset of the rash, and also parental concern, which clearly is always, I think, something to consider in any paediatric case. I think obviously novice practitioners, they tend to be more influenced by the availability heuristic because they've got fewer what we call illness scripts. They haven't seen a lot of different, varied, somewhat exotic, more complicated, more serious cases. They've seen a lot of what is common and in most cases is relatively benign, such as a viral illness. Okay. I think that while we're on availability heuristic, it can work in the opposite direction, in the sense that if you remember a vivid case and you recall that, so for example, we might have a case of a missed pulmonary embolism in a healthy young woman who had vague chest discomfort but no other clinical findings or apparent risk factors. We've all had cases where we've been surprised. That really wasn't expected. It was a process of exclusion and then finally the diagnosis was made. What happens then, though, is that we may then overestimate the risk of PE in patients presenting with similar clinical features. And certainly in my own emergency department, I see an awful lot of unnecessary CTPAs being done because people think this could be PE. It's a serious illness, yes. We have to consider it, we have to exclude it. But the thing is is it likely? And in many cases, if you do a pre-test probability assessment using a well score, for example, okay, these patients are very low risk. And we've done audits that show that in the vast majority of cases, the CTPA is negative. Okay, yes, there are occasions in which it's positive, but the point is, do we subject particularly young women to radiation, to the risk of allergy reactions, etc., when we think that the likelihood of a PE is very unlikely? So perhaps we could open this one for a little bit of discussion as well as to what you think there may have been, and you may feel, no, I didn't think that was really the big problem at all. I thought there were other things that were more relevant to this case. So again, we'll just have some time for discussion.
We do have plenty of time to play with here. We've got a 2-hour session, so please feel free to buy into this.
Hi, Ian. Brett Forge from Warrigal. One of the interesting biases in this sort of case is we're all seen patients that are referred to us, so we have this extraordinary bias in the type of patients we see. And we therefore often misjudge the situation for a general practitioner who might see hundreds of cases like this and for whom none of the above is the correct answer. But we automatically, I see some of the headache and I'm thinking of all sorts of organic things instead of exaggerating the risk of those things compared to other non-organic causes. And it does lead to some stress. We often, specialists are critical of GPs or other referring doctors because they don't think of something.
I think that, absolutely, you're right. I mean, I think we're lucky in many ways because things are often filtered by the time they come to us. And even in patients referred to us from ED, the ED people have done a fair bit of workup and they've gone through a thinking process. So I think we need to be careful not to be overly critical of that first contact, okay, because they're dealing with a lot more uncertainty.
I may comment actually on that as a general practitioner who is a occasional referrer to emergency department or to specialists for an acute case like this. And my greatest fear is that the patient will be subjected to some form of cognitive bias in their assessment, and because the reason why I'm referring is because of my concern, which is sometimes not founded in anything which is purely logical. It's more this does not fit my experience of a purely viral illness, and sometimes you have bounce back, as we see in this case, which is a unfortunate but I think unavoidable part of the system. That feeling of this is out of the ordinary is that what I would describe to the students, GP registrars that I train, to other medical students, when the hairs stand up on the back of your neck and you're not willing to go home and actually be comfortable overnight, then you know that something's going on and perhaps you need to relook at the case and think about referral. Thank you.
And Jeff Brown, then a question up the back and a question over here.
Thank you. Jeff Brown, paediatrician from New Zealand. I think just a comment here that although the parental representation and concern flag is possibly the most important, I think we have to be careful we're not putting our cognitive biases on a retrospective analysis of the case. And I can't see much wrong as a paediatrician with the first GP and the second GP presentation. It seemed entirely okay for everything that was in front of them. The parental representation, the ED maybe, but let's not buy into our biases in the analysis of this. I know this is a workshop about bias, but
Sure.
make the comments.
It's kind of the point, Jeff. Question up the back, then a question over here, and then one in the middle. Rod.
Yeah, sorry, John Dick from Townsville, Ian. I think, just to reinforce that second point there, whenever we're asked to see a patient as a second opinion, or the letter is worded from the GP that engages that mode of thought, or even just on the ward round and the reg says, I'm not quite sure, boss, about this one, you immediately switch to that thick slice thinking. And that's when you engage this sort of alternative process rather than the rapid round response.
Yep, please.
Jeff, sorry.
Go ahead.
Jeff Markov, Melbourne. One of the biases that hasn't been mentioned, but that I think is applicable in our discussion here, is hindsight bias. I concur with the paediatrician who spoke a moment ago that this case is notable because something went wrong. There may well have been many others, very similar cases where nothing went wrong and would never come up for discussion. Something went wrong, we're now applying hypervigilance to the events that occurred that led up to the changing of a diagnosis. I wouldn't necessarily refer to this as a mistake. You could say that a provisional diagnosis was made based on the information available at the time, and that provisional diagnosis was set aside when additional information came to light. You could then argue, well, was it set aside too late? Was it set aside at the right time or too early? From the information that was given, and obviously it's very limited, we don't know the details, I don't think it's feasible to necessarily say that it was set aside too late. I train registrars as well, and I ask them to explain to me what did they think and why did they think it. And because we can't interrogate the thinking process of the clinicians involved in this case, it's still very grey, and I think we should avoid the hindsight bias.
Rod Fawcett, then a question up the back.
Hi, I'm Rod Fawcett. Obviously, Grant knows me. I happen to be a chair of a major tertiary centre, i.e. Barwon Health's Mortality Review Committee, where we look at all the deaths in both the subacute and the acute part of the service, and that's 700 plus a year. I suspect every different group brings their own bias, depends on where they're in the system. And I think one of the other things that we need to be aware of, when anyone's placed under stress of any degree, they tend to narrow their focus and fall back on what they're comfortable with and lose the ability to think laterally. And the way this session's been framed, I think you're aiming at trainees understanding where the biases come from. And I suspect you put a bias in how you frame the session.
Thanks, Rod. Ian, do you want to respond to that? David?
Well, yeah, I mean, I think with this case, that's why we put in that last option. Was this reasonable? Okay, so we considered ourselves that, yes, we are perhaps introducing a hindsight bias. All right? I mean, you know, we can't expect perfection. And we need to sort of, and you're right, we need to go back and look at the thinking processes of the people actually in the case at the time. And of course, you can't do that retrospectively. Right? You may get them to think aloud as to what they did in hindsight, but even then, they may then secondarily rationalise their actions once they know the outcome. So we're always going to be, I think, bedevilled by, well, we can't actually get inside people's minds in real time and get them then to tell us that. But I think, and I think as well that this management of this case could have been entirely appropriate all the way through. So I don't disagree with that. I guess that we're saying, well, was there potential for a bias here? Was there a reasonable basis for saying this diagnosis was delayed, and could it have been made earlier? Were there other features about the system in terms of discontinuity between GPs and others that may also have led perhaps to a somewhat delayed diagnosis? At the end of the day, the patient did not come to harm, and that's great, all right? But, we understand that there is, I think, disagreement amongst us as to whether we feel this was perhaps not inappropriate at all in terms of how the case was managed.
Question off the back then, Peter.
Joe Maloney, I was a general paediatrician in Wagga for 30 years and mostly survived without registrars for the first 12 years, and my practice availability and sort of concern for patients was very hard learned. I really harshly judge that first case because there are several things you can say. Whenever a young baby comes in looking hot with a viral illness, there's a 1 in 20 chance it'll go back to remic, and whoever accepted care for that case in the very first instance should have maintained care. I don't care what you say to them when they leave, but you give them the mobile number and you stay available for the case. If that will prevent bouncing off general practitioners and giving the parents a sense that someone's following them through. It's quick when they deteriorate, and you're very lucky with that first case. The ED person who saw it should have rung the honorary, but there should have been a protocol system in place under a certain age whereby honoraries are always rung, and that honorary should have again accepted commitment right through. So I see it as a strongly sort of lack of availability case, regardless of who was cognitively what in their minds at various steps along the way.
David, do you want to reply to that?
I will, actually. I thank you for that perspective, and I thank you for being pointed about it. So later in this session, we'll be talking about systems level issues and how to approach that, and some of the recent thinking that's changed on how to think about systems and error and the issue of hindsight bias and how we approach causation. Thank you.
It's a good point. Organisations do have biases as well. Peter.
I thought maybe you could have up there also the 4-hour rule bias, because for it demands, and the workload that is demanded of junior medical staff sometimes in both the cases, so it demands junior people to make immediate decisions and move the patient on. They often make those decisions. A troponin's abnormal, a decision is made. So every time you need to stop and think, take a little bit of time, you're not allowed to. And so that drives, and it then certainly drives a lot of the unnecessary stuff that gets done, because, do something quick, move the patient on. And oftentimes that magnifies the problem, because the next person who picks the patient up where there isn't continuity then acts on a incorrect premise on the first offence, first time.
I think that's a very good point, Peter, and just anecdotally, my CEO came to us the other day and said, why is general medicine such a poor performer with respect to the 4-hour rule compared to other specialties? And I said, well, if you've got an acute heart attack with an ST supplement elevation and looking diaphoretic and sweaty, right, or you've had acute subarachnoid bleed, these things are fairly obvious, they're very urgent, and people will react immediately. But if you're dealing with an 84-year-old who comes in a bit off their legs, a little bit confused, mild fever, off their food, okay, well, that takes time to work out. And if we don't, and we want to make sure that we don't miss an important diagnosis that may require special input, we want to make sure they don't get suddenly sent to a ward in the middle of the night where perhaps they need to be monitored, etc. Well, you have to sort of spend some time using System 2 thinking to try to work out what's wrong with this person, and that may take you beyond 4 hours. So I agree wholeheartedly that we do have some perverse incentives in our system. And perhaps David may like to also talk on the system that actually predisposes to more errors simply because people regard that you've got to have everyone out by 4 hours. So I agree, I think it's an issue.
Yep. Any other questions or comments on this case? In the middle, Charlotte.
I suppose this is a can of worms. Barbara Hannon from Melbourne. But what are the chances of this landing on page 3 of the paper with the lawyers involved?
Pretty good.
Okay. This is something that everyone worries about, and certainly the managers, the hospital managers worry about. what is the legal precedent here. In fact, at a recent Choosing Wisely forum just last week in Sydney, there have been a number of cases of people doing good things. There was also a presentation from a lawyer who actually gave a number of cases where if doctors did a reasonable thing in terms of working through based on their understanding of the prevalence of diseases, how they present, what they do, the fact that the patient may have had perhaps not an ideal outcome subsequently, if what the practitioner did was reasonable and showing a sense of stewardship of resources, of not over-investigating, not subjecting people to unnecessary investigations, those cases then the court found that the doctor had no case to answer. Right, so and she presented about 4 or 5 of those sorts of cases. So I think we need to perhaps remind ourselves and also let others know that there are legal precedents whereby if you adopt a rational approach and you've got good justification for what you did and it's consistent with good practice, and I think we've had some discussion right here and now that people are saying this case actually was managed, there wasn't inappropriate management, then you won't necessarily be found liable. So I think that's the important thing. I think most cases of people going to court usually revolve around communication failures. So people aren't explained exactly what our provisional diagnosis is, why we're thinking it that way, explaining the management to them, clearly indicating if you have a concern, please let me know, get back to me. All right. So it's communication failure, right, and an absence of shared decision making, whereby people actually, parents, others, are brought into the conversation and are sort of told what's going on here and why we're doing certain things. And so if patients and others understand that, okay, you've done this all in good faith, but yes, and a bad outcome occurred, it's very rare that goes to court.
Question over the back. Can I just remind you while we're waiting for the question that Twitter is also the other reason to have a thing called a smartphone. Sonia, are you engaging in twittering in this conversation? Fantastic.
It's the world that we've invented a new cognitive bias.
Excellent. The 4-hour bias. Very good.
Please.
Yes, please.
I'm just thinking that if you go to a surgeon and they are going to operate on you, they talk about all the risks of the operation. And if we know that 10% diagnostic errors, should we be saying to the patients, at the end of this consultation, I'm 90% sure that this is the answer, but there's a 10% chance that it may not be the answer?
Yes, I think I don't have a problem with that at all. I think we should be honest with people and say, medicine is not 100% certainty science, and it's just recognising the obvious. So, but I think patients do appreciate some quantification of our degree of certainty, rather than say, well, I think this is what's happening, but I'm not sure. Well, that would make them feel a little bit uneasy, make me feel uneasy. But if we say, well, I'm 90% sure this is right, we have 90% confidence, but there is a 1 in 10 chance that perhaps this could be wrong, okay, then again, that's all part of the shared decision making. Patients then can decide what they want to do based on that premise. And they may decide, well, 1 in 10 is still not, I think, a worry for me, so I'd like more confirmation that perhaps we should delay doing this or that and perhaps do something else. Right? I think that's part of the conversation.
Before we move on from that point, and so taking it from a general practice point of view, so I find that issue is quite common when there's quite undifferentiated problems coming through the door, and so the best solution I found to that, and the one that's most acceptable to my patients, is where there's a joint discussion that's an involvement of patients within that discussion about certainty from the beginning, and it does require more time, and it does require more explanation about what we do know and where my thought process is. So I'm quite open with many of my patients, particularly where there's an element of diagnostic uncertainty, and that seems to reduce the risk of outrage when things are not exactly as I might have thought they were at the beginning.
We're tracking pretty well for time. We'll perhaps take 2 more questions on this case and then move on. Question up the back and then Les.
Could I just make the point, there's another layer of complexity, namely when you're dealing with a multicultural situation with language barriers that are extreme, and having practiced in Sydney for some decades, this is a really big issue.
Yes.
And especially when you're talking about uncertainty. That was really what sparked me to ask for the microphone.
Yes,
Liz?
I don't have a ready answer for some of the cultural expectations. It's very, very difficult, I agree. And you're not entirely sure, even with an interpreter, whether they're interpreting you correctly or giving the patient what they think they should be doing rather than what you're advising. So yes, that is a difficult one. All I think we have to do is perhaps try to have that conversation a couple of times. And if possible, to get it into some written form, all right, so they can go away and have a think about it, all right, before they commit themselves to a decision. But that takes time. I agree. It's a problem.
Please.
The other, Les Belatho, Wangaratta rural physician. The other analogy I use with patients is that they come along with a chronic complex problems, multiple, and I give them the analogy of putting all their information on the desk like a jigsaw, and we may get to the end of a consultation or in ED and we may not have the answers to each and every one of their problems, but at least we've got a plan for them put together. They all like to go away with a complete picture of the jigsaw, but we may have to get more information and do the diagnostic on it. And that way it allows me to reflect and then go back and have a look at, see what's going on with them too, and perhaps fit it into a different analogy.
Thanks, Les. Can I just test, can people up the back hear the questions? You can? Very good.
All right, okay.
Yeah, we're tracking well for time, but let's move on to case 3.
Okay. All right, so case 3. Joan is a 74-year-old lady with multiple comorbidities, including a colostomy following resection of a rectal cancer, who was admitted for respite care and assessment for long-term care placement. 2 weeks into her stay, she developed epigastric pain the late evening, which Melanta does not relieve. The on-call doctor is contacted, a phone order for opioid analgesia was made, after which she was noted to be sleeping comfortably. The next morning, she developed a distended abdomen, felt nauseous, had no appetite, started vomiting black-coloured liquid, and the doctor was again called back to review her. The nurses also reported some concerns regarding her colostomy, which seemed to be inactive, and there was a protruding stoma. She was reviewed by the medical officer on call that afternoon, who assessed her as having no abdominal tenderness on palpation. She had active bowel sounds, she had passed flatus, and she had normal vital signs. She was diagnosed and treated for viral gastritis, as her husband was also suffering symptoms of diarrhoea and vomiting at the same time that she came in, and the black vomit was determined to be due to iron supplements which the patient was taking. Over the next 24 hours, she continued to vomit this dark fluid intermittently. Her colostomy remained inactive and her vital signs became abnormal, with blood pressure lower than usual for her, but still within the acceptable MET parameters. But she did have a moderate tachycardia of 110 beats a minute. Viral gastritis, complicated by upper GI mucosal bleeding, was still thought to be the most likely diagnosis, given the absence of abdominal pain and any physical signs of peritonism, and the fact that she also had present bowel sounds. Unfortunately, at midday the following day, she was found unresponsive and resuscitation attempts were unsuccessful, and at post-mortem the identified cause of death was a perforated bowel. Okay, so which of the following decision-making strategies may have assisted in avoiding diagnostic error at an earlier stage? So a slight twist to the question: which of the following may have assisted in avoiding diagnostic error at an earlier stage? And the options are: considering and documenting the differential diagnoses, identifying and ruling out the worst case scenario, identifying signs that did not quite fit the working diagnosis of viral gastritis, considering if any red flag features were present that might indicate a more serious problem, all of the above or none of the above. So if you'd like to vote there on that one, please. Okay, so we have a total of 89 votes, okay, and basically the vast majority felt all these factors were relevant. Okay. 13 felt that considering if any red flag features were present that might indicate a serious clinical problem was perhaps the second thing to be considered in importance. Okay. Well, I think, again, we're not necessarily saying that we have the right answer. All right, perhaps we may defer to the majority. We're a democratic college. We felt we also felt that E, all of the above, were relevant in this case. Okay, so I guess, but leading on, if we can ask the next question, then we'll come up for discussion. What do you think, though, was still the main cognitive bias in relation to decision making around this case? So was it anchoring, premature closure? Was it availability, framing effects, base rate neglect, affective bias, overconfidence, or blind obedience? So again, would you like to vote on that, A to G? Yes. No, she's in an acute hospital. Yep. Okay, well, we've got again a bit of a spread. So we have 52 cases. I'll just refresh that. No, okay, 52. So some folk didn't commit themselves on this one. All right, so I guess the most common, though, was anchoring or premature closure, followed closely by base rate neglect, representative bias. Okay, and then we had 16% looking at framing effects, and then a smattering between availability and overconfidence. Again, all these factors may have some role to play. What we felt was the most likely, or perhaps prime problem here, okay, was anchoring. Okay, so again, premature closure, we perhaps also bring in another term called confirmation bias. Anchoring, premature closure, confirmation bias, they tend to wrap together. But essentially, I think that the clinicians that were treating this lady were anchored to this diagnosis of gastritis. Based on their initial impressions and the fact that her husband was also suffering symptoms suggesting viral GE. And then their diagnosis was further reinforced by confirmation bias, where we often seek and interpret clinical features in investigation results that appear to confirm our working diagnosis of gastritis. And we ignore clues that might actually disprove that diagnosis and perhaps suggest there's something else going on. In this case, there clearly was. And those sort of red flags or opposing clues were the fact that she had ongoing intermittent vomiting of dark fluid, because that clearly is not what you'd expect with gastritis. It tends to be more of a coffee ground vomitus rather than vomiting dark fluid. Inactive colostomy and a protruding stoma, suggesting that there is bowel energy here, which is rare in viral gastro. You'd expect her colostomy would be active and she'd be, passing a fair bit of stuff. The distended abdomen, which suggests that this may be a colonic problem rather than a gastric one. You can get abdominal distension clearly with an obstructed stomach, but it's much less likely. And obviously the onset of tachycardia and low blood pressure, which were not present at the onset of her illness. Okay, it may be expected as a result of dehydration, and I suspect that's what the clinicians looking after this patient probably thought. She was just dry, but it also means that perhaps she's developing now a septic problem or a shock problem. So perhaps we can have just some discussion around this case, because I think it's, again, not an uncommon presentation and clearly a bad outcome for this lady.
Bruce, and then a couple of other questions over here. Again, please introduce yourself and tell us where you're from.
Thank you. Bruce King. I'm from Nelson, which is in New Zealand. I just wanted to explore or get your distinction between anchoring bias and the base rate bias. Mm-hmm. One assumes you've got a decision already made and you stick with it. The other one says almost this, or to me seems very similar. Mm-hmm. You're not shifting, you're only working on half of the information in your diagnostic tool set. Can you distinguish the two?
Yeah, thanks, Bruce. I think, anchoring to me is that initial impression, right? Sort of the problem representation. I see this as gastritis, and then I anchor on it because it's my first impression, the one I like most. Perhaps the one that also suggests I don't have to do too much. It's a more benign etiology. Okay, just reassurance, fluids, and that's basically it. I don't have to do anything further. It's an initial impression. Base rate neglect is more, no, this patient has a number of features suggestive of this diagnosis, but this diagnosis is rare. Okay, it's really quite uncommon. It's the pheo question. So I have a patient who's a bit sweaty, a bit tachycardic, blood pressure up a bit. Okay, could it be pheo? All right, so yes, a pheo would certainly explain all those symptoms, and there's nothing here in this presentation that would suggest that that wasn't possible. Okay, but it's highly unlikely because pheochromocytoma is a rare diagnosis. All right, there's likely to be other causes for this patient's sweatiness, slight tachycardia, hypertensive. Could be just pure anxiety, all right, or someone who's getting perhaps some sort of drug withdrawal reaction because they've just stopped their benzos or something like that. That would be a lot more common, and they're the things that you need to think about before you hit the pheo. All right, I think in this case, viral gastritis is common. Perforated bowels in old ladies with colostomies, well, that's not perhaps rare either. That can happen. So I think it's more the initial impression. I anchor on that. I kind of like that. It's the one I favour most. Right? And I think too there is a tendency sometimes to underrate patients' severity of presentation because people may feel, well, that makes the patient feel better that they're reassured that there's nothing serious going on here. It reassures me. I don't have to again do too much. All right? But I think in this case that anchoring persisted longer than it should have, and there were definite red flag that should have thought otherwise.
So let's get the order right. There are 2 or 3 questions in the middle here, then a question over here, then Peter, then a question up the back.
Thank you. Robin Youngson. I'm an interloper because I'm an anaesthetist, not a physician. So
You're at the wrong conference.
So I'm the guy that I'm the guy that gets called to this patient when she's in a state of collapse. So I have a bias already, which is a retrospective bias. I don't know what kind of a bias this is, but the thing that I observe is it's a kind of a reductionist thinking that has a comfort in a diagnosis without actually looking at the whole patient. And from the anaesthetist perspective that gets called multiple times to medical wards to resuscitate patients, there's a failure to look at the whole patient and see that the patient is sick and has subtle but all the signs of an elderly patient that's about to die of septic shock with a perforated bowel that seems really easily apparent from my experience, then it seems very hard to see often from, but that is a bias in that. So I don't know what kind of a bias that is, except that it seems to be something about kind of reductive thinking and an inability to look at the whole picture.
Well, I agree wholeheartedly, and I think that is the problem with anchoring. It does simplify the problem for you. It's cognitively easy to think more broadly and to think of the whole patient and sort of say to yourself, this person looks sick. I don't think this is enough to justify her feeling this way. Yes, then we have to think more broadly. And I agree with you. Often you will come along to a resus and a new pair of eyes come to this patient, all right? So you don't have the anchoring effect. You're now in a situation, you've got to look at this entire patient, see what's going on here, think about the differentials, what are the possibilities, okay? And that's why then the diagnosis, correct diagnosis, then often comes from that sort of interaction. Because everyone else has become familiar and comfortable and anchored to a certain way of looking at this patient.
Question here, then I think there was one more question in this part of the room, then over here, then back to Peter.
Cheryl Johnson, I'm a geriatrician from Auckland. This is quite an interesting case, and I think it demonstrates also that when you're dealing with older patients that they do present atypically, and there's certain diagnoses that you've always got to have in the back of your mind. One of them's ischemic bowel, and anyone who's abdominal pain, similar sort of thing to here, things like PEs, which will often present atypically. So I teach my juniors the art of the differential diagnosis to, if it comes into your mind, add it to your differential diagnosis, and then go through that and think, is this what this is? This lady would have benefited from some investigations, at least an abdominal film, something like that, to kind of push you towards that diagnosis.
Yep, agreed.
Question, Rod again.
Yeah, it's Rod Fawcett again, mortality review hat on. I think what we are doing a lot of is, because of time pressures, we're not going back and fully reviewing. We have a deteriorating patient in this case, and my anaesthetic colleague, I think, hit the nail on the head. At what point do we say, hey, yes, what we've learned
we need to go back and restart with a clean sheet and have a really good look at what's going on, because this patient's deteriorating and we don't really have the answers. Yet I see a reluctance to go back and fully review the situation because of the time pressures people are under.
Mm-hmm. Good point, Rob. Question over here, then Peter Deveron, then a question over the back left, and over to you. Good to see so many hands up.
Kim Jeffs, geriatrician from Melbourne again. 2 comments. One is that we talked particularly with the first case about fragmentation of care and too many people, too many cooks spoiling the broth. This may have been a case, as you said, where an extra cook in there actually saying, hang on, this doesn't fit, would have been good. So one way of getting rid of confirmation bias is actually to bring in new eyes. Yep. The second comment that I would make is, and I agree that this is the main bias, but this was a woman who was destined for high-level care, and there may well have been an effective bias there. Who wants to spend money on the lady who's going to a nursing home anyway?
Yep. I'm sure that very few people would admit to that, but I suspect that may certainly have a role to play.
Yeah, indeed. Question up the back. Sorry, Peter. I think I've got a bit out of order here. Too many arms. We'll come to you.
Sorry, Lisa Mitchell from Geelong, geriatrician, only adding to Kim's point that I wonder if ageism is a prejudice that people have that mean that they do spend less time assessing patients, particularly ones that are going into residential care.
All right. Well, I think, can I just speak for myself in the sense that I'm a general physician and we treat a lot of older patients. Our median age would be about 76, 77 years. So I think this sort of awareness, looking at, again, older folk who often have multiple problems, can present atypically, right, may present with sort of non-specific features, right, you've got to think widely and you've got to have a broad differential. And I think that's probably the most important message to get across. And then, yes, certainly to seek a second opinion.
Thanks, Ian. Peter Deveron.
There's also the bias of being in the wrong place at the wrong time. If she'd have presented to the A&E department, she'd have had a CT scan and the diagnosis would have been made on the spot. The fact that she gets an acute illness in a person who's in hospital for a rehabilitation type reason, people sort of forget that, hang on, other things can happen. So if she'd have got her illness at a different day in a different place, it wouldn't, that's not an uncommon event in inpatients that people don't pick out, for instance.
Yep. A bit of a framing effect, yep.
Sonia, can we tweet about that? The bias of being in the wrong place at the wrong time. Question up the back.
Grace Walpole, palliative medicine advanced trainee from Melbourne. I'm interested in your reflection as to the extent to which the biases can be we can perhaps have multiple biases in each case. One, we're kind of teasing out one to talk about. I wonder whether, and perhaps this comes to some of the points that have been made already, the biases can in fact reinforce each other to cement a situation. Is there discussion about interaction between biases?
Sure, there is, and I think that, as I mentioned, a lot of these biases do somewhat overlap, and they may be interdependent, and they may be mutually reinforcing. I think what we've been trying to do here is, perhaps by teasing out what we think is the prime one, is that at least then we can perhaps develop a better understanding of each of them in turn, and perhaps the situations where, okay, this particular bias may be more prevalent, exert more influence on our decision making than others. But your point is well taken, and I think that's reflected in the kind of spread of responses. I think, you need to look at each case in total, and there may be other biases which are sort of second or third order, which also should be considered and talked about. I think for the purposes of our workshop, we wanted to sort of narrow down on a few.
Question down the front and then 2 questions up the back.
So just in terms of this lady, I was just wondering if there had been thought about what other differential diagnoses were. I'm just wondering if the outcome it would have been the same at the end of the day. Just that we would have been able to have a conversation with the family about the diagnosis and the fact that her prognosis was pretty poor. And palliation would have been put in place. She would have probably died.
I'd love to comment on that if it's all right. I really appreciate that, thank you. And I was going to mention before the issue of location of the patient and the bias associated with that. And I palliative care is one of, I've had a very great experience with training with palliative care physicians. Yes, and I think the quality of life issues, even if the outcome's the same, I think is a missed opportunity in this particular case. So I really appreciate that comment. And I think that, yes, potentially location, in response to the other question about bias associated with location, is important. Because some locations will be associated with particular biases, silos, and particular specialties that do have a particular focus on diagnosis. So I'm a personal believer in using palliative care in it to improve quality of life, even if the outcome is the same. And so in this particular case, yes, I think that would be a very worthwhile outcome.
Thanks, David. 2 questions up the back.
Hi, Chris Hammersley, occupational physician. I don't think anyone enjoys the position of being an outlander or outside of a body, and we're trained as practitioners to absorb orthodoxy. But I wanted to say I've seen the word confirmation bias spelled conformation bias at times, and I think they both have different meanings. One is an intrinsic finding of a solution you're looking for. The other one is more, I don't really want to be the one who's saying something different here several weeks into a case. I do some extensive file reviews lasting 3 or 4 years at times, and I see this happening where people are just copying what's been written before as a kind of shorthand, or it's too much trouble to get down to underneath what's really happening. I wonder if you could comment on conformation as an aspect of this bias.
I think that might come under what I call sort of blind obedience as well. Okay, so in other words, you're conforming to the opinions of others because you think they're more expert than you, they're more senior, they've got authority and charisma. Who am I to sort of be challenging a diagnosis? Clearly that is not what we want to see. And we should have our juniors, our residents, our interns questioning the diagnosis, adding in their thoughts, and asking them on ward rounds even, what do you think about this case? I'm a bit perplexed. Okay, I mean, we should be using the eyes and ears of all our team, and including nurses and others too, all right? So I wholeheartedly agree. I think we can lock ourselves into just going along with the diagnostic momentum, and we need to sort of counteract that.
Thank you. Second question up the back, and then a third question up the back.
Bill to further geriatrician, this time from Sydney. The issue of prejudice has been raised several times, but it may not actually. Well, it's ended in the individual who was assessing the case, but the culture in which that person works in, where cases from nursing homes are not looked on favourably in presenting to acute hospitals, has an influence as well. If you work in a system where you'll get a nasty phone call for sending a patient in from a nursing home that ended up not being unwell or having gastro, where you thought was a bowel obstruction, that influences GPs, I imagine, quite heavily in terms of what they do. So to generalise, if a registrar is going to be grilled by their boss for making a phone call overnight, their decision making is going to be heavily biased in a certain direction.
Well, I think that's bad role modelling on the part of the consultant. They should be prepared for the fact that, okay, it may be easy for me to make a decision that this is probably just something simple, but you've got to put yourself in the eyes, in the place, in the shoes of the people who are there actually making the decision. Certainly, by all means, go feedback and explain your rationale as to how you see the case. Perhaps correct any misinterpretations or misunderstandings that the registrar or whoever the person is may have, but berating them for saying, why did you bother me about this at 2 a.m. in the morning, is certainly not the way to go. So I don't think anyone would countenance that. Yes, it may happen, but I think that's not the role of a teaching consultant.
Further question at the back and then one at the front.
Could I just comment that at Prince Alfred, certainly over decades, there is a very big component of diagnostic medicine and palliative medicine. A large part of it was trying to sort out what on earth is happening. And I had a view that one came to a provisional diagnosis that sometimes was fairly strong evidence, but I used to try and teach people to think of what else could be the case which would be managed totally differently, and literally go through that diagnostic, that discipline, and think it out, because one of these days you're going to be right with regard to the second one, and you may save a disaster. Just a comment, really.
Sure.
Yep, please.
Karen Dunn, emergency physician. I'm just wondering, you were alluding to the idea of wishful thinking and whether we need a wishful thinking bias on the list, because we don't know what the junior doctor might have been thinking, and they may have wished that it was the lesser illness because they don't know what to do if they get to the other diagnosis. And I think this is an issue for many of our junior staff, that they then don't do the septic workup because they think it's a difficult thing to do, so I'll wish it was a viral illness. And that it might be a useful thing to add if we're teaching juniors about sort of biasing categories, the one of wishful thinking.
Yes, well, a good point. And actually, the people have used that very term. So wishful thinking bias is actually reported by some. So it's there. I think it comes back to, as I said, there's sort of, I guess, desire sometimes to wishfully think, not perhaps necessarily also just to save me time, to have to sort things through and do other things, but also because, you know, I like this patient. I want to reassure them that there's nothing going on here, right? And they're kind of looking at me and hoping that I'm going to say something that reassures them. So I think that may be a form of affective bias coming in as well, you know. Your point's well taken. I think that that's something else we need to, I think, make sure that people understand that, look, you may want to wish things away, but that's not the role of you as a doctor. You've got to go the next step. You've got to go the full hog. Yes, it does impose now some complexity and cognitive load on you, and responsibility as well. If you think about something, then you've got to follow it through. And how many times do we see on an admission from a registrar, well, query PE, but then nothing after that differential. There's no consideration of D-dimer, or should I do a CTPA, should I do a venous ultrasound, should I consult someone about this, perhaps start the patient, perhaps even now on heparin until we can be more certain, etc., etc. But it's there, all right? They've thought about it, but they don't want to go that next step.
We'll have 2 or 3 more questions on this case and then we'll move on in the interest of time. Question up there back.
Yes, hi, Ross Upshur. Really enjoying this, but a couple of, just an observation. Not all errors in reasoning, in diagnostic reasoning, are necessarily cognitive errors. They can be logical errors as well. So I'm a profound advocate of the type 2 type thinking and have tried in my career to get residents and learners to actually take very seriously the time to learn how to reason carefully, because many of the errors that we're saying are biases or kind of cognitive errors are actually logical errors. So we need a companion logical approach to diagnostic reasoning that focuses very much on what I'll call defeasible reasoning schemes, or what's in informal logic called defeasibility logic. Ironically, also what underpins artificial intelligence, but it's something we can actually get humans to do. The other thing is to actually teach people that diagnosis is always differential and always provisional. So there's always a possibility that it can be overturned, and I had a method that I taught where I'd give my residents $1 representing one unit of probability, and how would they partition that, and insist that they partition it at least 5 ways. If they were going to bet it all in $1, they had to put it in a cup, and then we would follow up, and at the end of the year we had a large amount of money in that cup. And it's a way of actually getting people away from overconfidence bias.
Thank you.
2 more questions in the middle.
I like that.
Yeah, it's Rod Fawcett again. This time I put a junior medical officer hat on because I work a lot with junior medical officers, particularly interns and PGY2s. I would like to put another concept there. There's an assumption bias, and that is made by the consultants and the teams, that they assume their very junior medical team members actually understand what's going on and what the thought processes are. I deal a lot with juniors that haven't understood, and it's as the chair of our mortality review, it's one of the major reasons I write to units asking them to explain their thinking and why they went the path they went, because it's not documented and the juniors haven't understood it. Yet they're left to clean it up after the fact in terms of writing death certificates and summaries, etc. And it's blatantly obviously when you look at those documents, they haven't understood what the thought processes were.
Yep, that's an excellent point, and I would really reinforce that. We do need to take the time on ward rounds to think aloud and to actually explain to people, why we're thinking what we do, and again, to perhaps expose. Well, we're not entirely certain here, and again, that's inviting others to voice their opinions and their thoughts about the case. We look at every death and we look at every near miss and we look at the death certificates and we look at discharge summaries, because I think that's another method by which you can understand, well, did the junior officer really get their head around this case in the way they presented the in-hospital course and the discharge summary. So I agree, there are things that we can do and should do and to make sure that our juniors understand what's going on.
Okay, last question on this topic.
I guess it's partly a comment. I'm Tess Olivares, I'm a fairly junior general physician, and just remembering as a registrar, I'm just interested that blind obedience is considered a cognitive bias when I think in many respects, if you are the more junior person in the system, it's a systems error almost, because it's actually very, very difficult to challenge that situation if you are the more junior person. So you can ask a question of someone more senior, you can say, could you explain that to me? But in the end, if they say this is correct, there aren't that many mechanisms where it's very easy to get round that. And I know that the system can be really punitive about that. So we had a case in our hospital where a very junior member of staff got criticised when as an RMO assisting in a surgical procedure that didn't go well, that they didn't challenge the surgeon who was the expert in that when things went poorly. Now that was actually what the sort of coronial findings were, was that should have been challenged. But when you think about it, how inherently difficult that is, I've listened and done what I've been told and had a patient die, even though I did ask the question. I've also, in very memorable circumstances, had to ring a different head of department from outside of the hospital because I couldn't get an intensive care doctor to be involved with the case because my senior physician who was on call disagreed with what I wanted to do. And so, there are really difficult scenarios that can evolve. So I wonder if that is all cognitive bias or perhaps a big sort of difficulty in the system.
David, over to you on that one.
We'll discuss some of the general frameworks, which and a further discussion around these particular issues, because I think, in short, we're focusing very much on what we can do personally, but we're not quite yet in this discussion considering how much of these biases are actually generated through the systems that we work within, which they say.
And the nature of the profession. Ian, let's move on to case 4.
Okay, so case 4, 65-year-old male with past history of treated small bowel lymphoma, presents with malaise, upper abdominal pain, deranged liver function test, which had been normal 1 week previously, and thrombocytopenia. Physical examination reveals a mild fever and tenderness in the right upper quadrant, and abdominal ultrasound shows normal liver texture, no dilatation of the biliary tree, and a normal gallbladder. Coagulation profile is not consistent with the DIC. After the taking of blood cultures, the patient is commenced on broad-spectrum antibiotics, but his liver function tests continued to worsen. A consult is sought from the GE unit, and the GE registrar, after reviewing all results, postulates a broad differential diagnosis including cholangitis, acute viral hepatitis, recurrent small bowel lymphoma, drug reaction to concomitant proton pump inhibitor, even though the patient had been on this for some time, or autoimmune hepatitis. She also requests, just for completeness, and that's actually written in the record, iron studies, copper studies, antitrypsin 1 assay to rule out hemochromatosis, Wilson's disease, and antitrypsin deficiency. All right, so which of the following statements describes the diagnostic error inherent in this registrar's thinking? So, A, most diagnostic errors are caused by failure to undertake the most appropriate investigations. B, diagnostic error often reflects lack of knowledge of atypical presentations of common clinical syndromes. C, ordering comprehensive test panels when considering a large list of differential diagnoses is likely to yield a correct diagnosis. D, diagnostic error can be reduced by selecting investigations based on a careful consideration of pre-test probability. or E, all of the above. So we're saying which of the following statements best describes the diagnostic error or the diagnostic missteps in this person's thinking. So would you like to record your answer there, please? A to E. Okay, so we have 69 votes, and the majority opinion is diagnostic error can be reduced by selecting investigations based on a careful consideration of pre-test probability. The next in order was diagnostic error often reflects lack of knowledge of atypical presentations. 11, ordering comprehensive test panels when considering a large list of differential diagnoses. Okay, so I think you could argue really perhaps D or C really I think are the two options to be considered, and our feeling was on this particular case we thought that ordering comprehensive test panels when considering a large list of differential diagnoses is likely to yield the correct diagnosis. In other words, we're saying this we think is the error or the assumption that this doctor was making at the time that she saw the patient and then asked for the investigation she ordered, basically hoping that the right diagnosis would come out of those investigations. Now, I think you could argue that perhaps, considering pre-test probability is also valid, and I agree with you. And I think that there are other options that could be considered in this case. So, again, we're not saying that we have necessarily the right answer. At least that was the way we called it. So,
I suspect there'll be some discussion.
There will be some discussion. There will be some discussion. I guess that before we move, and we'll come back to that, but perhaps we could just do the next part of the exercise first, and that is, again, what do you think was the main cognitive bias here underpinning this registrar's thinking? Again, anchoring, availability, framing, base rate neglect, affective bias, overconfidence, or blind obedience. So again, if you could record your answer, please, from A to G. Obviously, the day gets longer, the server gets more traffic. Okay, well, we need to have our circle a bit larger, but still, I think we can say with confidence that 2/3 thought that base rate neglect was the issue here, and then there was a smattering, which we won't go into, of some of the others, but the majority was base rate neglect. Okay, and we felt that was the answer too. So in other words, there was uncertainty about the cause of this patient's worsening liver function tests. Okay, but this then the GE registrar, and we do see this. Certainly my concern is whenever I ask a junior trainee from another specialty that they will come along and tend to be a bit blunderbuss and menu driven in what they do. So they have sort of, well, we have a list of things we have to think about if we're a consultant to anyone who's got abnormal liver function tests, and that kind of gets then blindly adopted. And we know that the last three diseases that she mentioned for completeness, and this is a real life case too, by the way. Okay, one of my cases. The last three diseases mentioned, they're really highly unlikely. In fact, you virtually exclude them by the way of the presentation, the fact that this patient's liver function tests were entirely normal up until about 1 week before presentation, and the normal appearance of liver and ultrasound. So again, well, and these are rare syndromes. Wilson's disease, very rare. Hemochromatosis, well, perhaps not so rare, but still there would have been lots of other suggestive features of that, and the patient would have presented earlier. So this is where I think, again, we need to teach our trainees that, okay, think about worst case scenarios, but also don't be over-inclusive and start investigating things on the basis that, well, this is our list and we go through the list when really there's very little chance that this is relevant. Just to be complete, I think is something we should try to get rid of amongst our trainees, and certainly I tend to see it more in specialty practice amongst various specialty units. And in particular raise the possibility that you may then get false positive results as a result of those extra investigations, which then again lead the patient on to another cascade of further rounds of investigation and sometimes inappropriate treatment. So I think it certainly underpins a fair bit of what I would call low value care in our hospital. So we'll open that one for discussion.
Questions, comments? Up the back, Karen again. Getting quick.
Hi, Patrina Corwell, Sydney paediatrician. I would like to think, I'd like to propose that there might be another bias that paediatricians have, which is paediatric bias. So if I've got a little kid and I'm going to have a blood test, I'm going to order as many things as I can, and we do that a lot. Yeah. And it's probably bad practice, but we do that a lot, well, some of us.
Thank you for being so honest.
Me again. I guess this is kind of damned if you do and damned if you don't, isn't it, as a junior doctor? So before we're going, well, you should have been cleverer and thought about more things, and now we've got a doctor who's been super clever and has thought of a whole list of things, so we go, well, no, that's too clever, you have to back off a bit. And you know, and we have to appreciate that the junior doctors are training and they don't know everything, and sometimes they don't know enough, and sometimes they can't actually sort things out, you know, with a whole list of tests. And then it's our job as consultants, really, to be available and to fine-tune things.
Mm-hmm. Yeah, I'm sorry, I totally agree with that. I think that when I, you know, in relation to this registrar, I actually, you know, came along, she sort of came back and I said, you know, do you really think this is likely? You know, this patient who's got Wilson's disease and hemochromatosis? And she admitted, no, I don't. And I said, well, you know, was there a reason then why you ordered the test? And she says, well, you know, in our GE unit, we can recall cases where, yes, these patients have presented atypically and late, all right? But I said, yes, but how frequent is that? Is that, you know, common? Is it everyday experience? And she said, oh, no. But, you know, we remember the esoteric cases, all right? And again, the availability heuristic comes in as well, where we recall that unusual case presented at grand rounds or in our unit meetings and so forth, you know, and that can then, again, get us to overestimate. Yes, these things can occasionally happen, but still, it's most unlikely. And this particular patient, there are other things on your differential that you considered higher up, and you did feel that was more likely. But for the sake of completeness, these other things were added in, which really were not likely at all. So I think we do. I think many of our registrars, you know, they do have a certain amount of knowledge already, and I think we should try to, I think, build confidence in them in deciding. Perhaps don't order those other things just for the moment, okay? Go with what you think your gut feeling is telling you, what you think is most likely. Let's see then what happens in relation to the results and how this patient may respond. We may then need to come back to that lower order differential and perhaps consider those possibilities at a later time, but we don't need to sort of do them all now. I think in relation to the paediatric case, and this does happen too, I think in ED, particularly under 4-hour rules and the pressure of doing things, and this is something that comes up in the literature, should we do all the things up front anyway? Cover all the bases, that way then we get those results back more quickly, we can perhaps get to a diagnosis more quickly, etc. I would say no, we really shouldn't go down that path, because that does lead to a lot of unnecessary over-investigation. Right? And we will have false positives, and sometimes in case false negatives, but we'll certainly have more false positives, because tests will tend to be more false positive if the original pretest probability is low, irrespective of how good the test performs in terms of sensitivity and specificity. All right, so we need to get that message across. So I think, you know, that's not to say you shouldn't rule out the worst case scenarios, because even if they're unlikely, if they're lethal and you can treat them, then clearly we can't miss those. But I think there's this a very large area in the middle where perhaps we're subject to over-investigation.
Thanks, Ian. Jeff Brown, and then up the back, then Sue. G'day. And Liz.
In response, Jeff Brown here, very general paediatrician from the Manawatu. I appreciate everything you're saying, but in defence of the registrar, the junior doctor, and heading to our systems problems, we model wrongly. My effective bias is that the more subspecialty is, the more likely the thought process, I think it popped into my brain, therefore we need to test for it. And we model that, and there's no wonder that we get that sort of response when somebody's asked to do a consult.
Yeah, listen, I agree. It plays out, and you also see it on practice exams. Okay, and I examine, but I often have a specialty colleague there, and the candidates you can see, they're kind of saying, well, it could be this, and this, and I would do this, and we get about 10 investigations all in a row. Okay. With no sort of ordering or, okay, what's most likely, what's the thing I should do now, perhaps what I should do later. So in those cases, I try to, ask our trainees to think in a different way, and certainly we should role model that in both our ward rounds and our teaching, but also perhaps in the exam too, because the exams often drive the learning and drive the way we do things. And I actually tell my trainees, well, look, you may get to, if I examine you, you'll get somewhat demerit points if you come out with 20 investigations with no ordering and no considered and prioritised differential diagnosis, because that's the way you should be thinking. All right, we're not here to examine you to think of, is this a candidate that's got so much knowledge and is thinking so cleverly, comes up with 20 different things that this patient could have and then tests for them all. That to me is not the way we should go. But you're right, and we need to role model that.
Charles, you've got a question up the back?
Hi, Bill Too again, geriatrician, Sydney. But the fact is that this is a trainee and it's been raised as trainee for a particular reason. But this, I think, is part of their learning process, though. They go through this process of having huge checklists, and as they become consultants, they prune that down. I guess they develop a better heuristic. And one of the metropolitan hospitals in Sydney did a observational study of how trainees go through the exam. The first year trainees, basic trainees, went through Talley and O'Connor perfectly. The second year trainees about to do the exam very much picked which aspects of an examination in history they needed to concentrate on in a long case to be more efficient at their time. So the process of how they think and develop a diagnostic does evolve, and I think this is just part of it. I mean, we're here to assist them in the process, but I agree we shouldn't be overly critical of the process.
That's fine. I don't think, and I'm not trying to be overcritical either. I think we perhaps just need to evolve that thinking. We can perhaps do it a little faster than what we are doing at the moment.
Sue Maloney,
a paediatrician from the Gold Coast. 2 points. One is there's the opposite paediatric bias in that to get medical imaging on an infant or a young child, you need a general anaesthetic. And so I think in the opposite way, we think very long and hard about that, and we have to get them into our MRI scanners in a big, busy hospital. The other thing is I think we're looking at this on where things went wrong, and I don't think we look carefully at where things went right. And every now and then in our hospital, in our unit, we get a case that's not too obscure, but we actually look at why somebody got it right early on in the process. And I don't think we as a profession are really good at looking at where things went right. We focus a lot on where things went wrong to try and make ourselves get right. But I think every now and then it's probably worth taking a step back and thinking, I can think of some memorable cases where I think, why did you do what you did? You did it really well. It happened quickly. It was an rare case. You had to change the way you think. In the middle of this minefield of febrile infants, you actually got the one that was really sick that didn't really have a lot of extra stuff there. So I think we sometimes need to look at why it went right rather than just why we had error.
Yep, agreed, absolutely.
Okay, we've got 5 minutes to go on questions, and I will stop it at 12:15 by my watch, because I'm determined that we finish at 12:30 so that we can get to lunch. Les Blytho.
I think Les Blytho again. I think this is a combination of a system fault or a system problem and a framing bias, because you've called in the gastro registrar for abnormal liver function tests, ignore the fact that the patient's febrile, is having a systemic reaction to whatever's going on. And I think we sub-fragment our patients. This specialisation to segments of the patient really is a problem, and I think we've got to overcome that along the way.
Question at the front.
Yeah, it's just a comment actually. I'll just make it quick because there are probably other questions. So I have worked with some advanced trainees from third world countries like Sri Lanka, and they have very limited resources for the same size of hospital as I have worked with. And because where they were limited resources, they would order investigations after very thoughtful thinking. Not just because it's available that you can order alpha-1 antitrypsin, so just order it, throw a net, and you might find something. So I think that is something we should consider and remember.
Dave?
Yep. All I'll just say is hands are free, and that's digital imaging. And remembering that is important. And actually one of my mentors, who I will name, Tony Delaney, who works at the Australian Institute of Sport as a sports physician, taught me that rule, and I'll never forget it. And it saved me many CT scans, many MRI scans, and a lot of money for the system appropriately, because I could make the diagnosis without sending them on for further investigations. I agree. Thank you.
Thanks, David. Question over here.
Danny Delore, paediatrician from Rotorua. It's a really great session, thank you. The cases we've discussed really focus on diagnostic error and cognitive bias, and I wonder about the cognitive bias and how what we're talking about translates to management and therapy.
Yep.
Diagnostic error is important for sentinel cases and coronial cases, but the burden of disease on the population may be even more impacted by our bias on management and therapy. I'm thinking of, for example, this patient seems not very educated. I don't need to spend time explaining things to them. These parents don't seem very motivated to prioritise what I prioritise. I'm not going to spend time getting them back to clinic, etc. So I just wanted interested in your comment about how translatable this discussion is to management and therapy, even when we know the diagnosis, and what you think about the burden of our bias in management and therapy compared to diagnosis.
Sure. No. Well, I did think about that in this session, but we thought we'd be biting off more than we could chew if we also include management error as well as diagnostic error. And we thought, well, perhaps diagnostic error should come first, because everything downstream in management is going to perhaps be, fraught with problems if you've got the wrong diagnosis or delayed. But your point is well taken, and some of the references that we cite and talk about management bias as well as diagnostic bias. So it's purely just a question about focus for the workshop. But if we want another workshop in the future on management bias, I'm more than happy to help.
Thanks, Ian. Thank you. That's a really nice question to finish that section on. Jennifer, last question.
Jennifer Alexander, retired medical administrator. On this issue of management bias, one of the questions which has been going through my mind, and thinking about the work of Kahneman and Tversky, is really whether these are just a subset, the diagnostic error categories, of decision making. That is, if you look at their work, they talk about generally, they started on general decision making, of which the medical decision making became a subset. And so whether the answer to the question about management bias may actually lie on what we've been dealing with, that we've actually applied a thinking process to the diagnostic process of medical decision making, when the same biases may well apply in management. And for example, in HR and selection of staff, there are lists of biases about we tend to pick people who look like us in characteristics. So it may be that you already know the answer to that question.